Hello class, welcome to Chapter 33, Obstetrics and Neonatal Care. After students complete this chapter and the related coursework, they will understand the anatomy and physiology of the female reproductive system as it relates to pregnancy. They will learn the assessment and emergency treatment for childbirth, including stages of labor, normal delivery, complications of pregnancy, and neonatal evaluations and resuscitation. Introduction. Most deliveries occur in the hospital with doctors and nurses and attendants. Occasionally, the birth process moves faster than the pregnant woman expects, or she is unable to get to the hospital. You must then decide whether to assist the delivery on scene or transport the patient to the hospital. Anatomy and physiology of the female reproductive system. The female reproductive system includes ovaries, fallopian tubes, uterus, cervix, vagina, and breasts. The ovaries are two glands, one on each side of the uterus, that are similar in function to the male testes. Each ovary contains thousands of follicles, and each follicle contains an egg. During each menstrual cycle, there will only be one follicle that is successful at maturing and releasing an egg. Ovulation occurs approximately 2 weeks prior to menstruation. If fertilized, the egg implants in the endometrium, the lining of the inside of the uterus. If the egg is not fertilized within 36 to 48 hours after it has been released, it will die and the lining is shed as menstrual flow. Occurs around the 28th day of a woman's cycle. The fallopian tubes extend out laterally from the uterus with one tube associated with each ovary. Fertilization occurs when the sperm meets the egg, usually when the egg is inside the fallopian tube. The fertilized egg then continues to the uterus where, if implantation occurs, it develops into an embryo and then a fetus and grows until the time of delivery. The uterus is a muscular organ that encloses and protects the developing fetus for approximately 9 months or 40 weeks. The uterus produces contractions during labor and ultimately helps to push the fetus through the birth canal. The birth canal is made up of the vagina and the lower third of the uterus, called the cervix. During pregnancy, the cervix contains a mucus plug that seals the uterine opening, preventing contamination. When the cervix begins to dilate, this plug is discharged into the vagina as pink-tinged mucus, or bloody show. The small amount of bloody discharge often signals the beginning of labor. The figure on this slide shows the atomic structures of a pregnant woman. The vagina is the outermost cavity of the female reproductive system and forms the lower part of the birth canal. It begins at the cervix and ends as the external opening of the body. The vagina completes the pathway from the uterus to the outside world for the newborn. The peritoneum is the area between the vagina and the anus. In pregnant women, the breasts produce milk that is carried through small ducts to the nipple to provide nourishment to the newborn once it is born. Early signs of pregnancy in the breasts include increased size and tenderness. The placenta is a dish-shaped structure attached to the uterine wall that provides nourishment to the fetus. It is connected to the fetus by the umbilical cord. The placental barrier consists of 2 layers of cell, keeping the circulation of the woman and fetus separate but allowing substances to pass between them. Anything ingested by a pregnant woman has a potential to affect the fetus, including nutrients, oxygen, waste, carbon dioxide, many toxins, and most medications. After delivery, the placenta separates from the uterus and is delivered. The umbilical cord is the lifeline of the fetus, connecting the woman and the fetus through the placenta. The umbilical cord vein carries oxygenated blood from the placenta to the heart of the fetus. The umbilical cord arteries carry deoxygenated blood from the heart of the fetus to the placenta. The fetus develops inside a fluid-filled bag-like membrane called the amniotic sac. The sac contains 500 to 1,000 milliliters of amniotic fluid, which helps insulate and protect the floating fetus. The amniotic fluid is released in a gush when the sac ruptures, usually at the beginning of labor. Normal changes in pregnancy. During pregnancy, many normal changes occur in the body that are not all directly related to the reproductive system. The primary system involved with these changes are the respiratory, cardiovascular, and musculoskeletal systems. In the reproductive system, hormone levels increase to support fetal development and prepare the body for childbirth. This puts pregnant women at an increased risk for complications from trauma, bleeding, and some medical conditions. As fetus develops and grows, the uterus also grows, stretching to accommodate a full-term fetus. As the size of the uterus increases, so does the amount of fluid it contains. Uterus is displaced out of its normally well-protected position within the pelvic area. This increases the chance of direct fetal injury in trauma. Rapid uterine growth occurs during the second trimester of pregnancy. As the uterus grows, it pushes up on the diaphragm, displacing it from its normal position. Respiratory capacity changes with increased respiratory rates and decreased minute volume. Overall blood volume gradually increases throughout the pregnancy to allow for adequate perfusion of the uterus, prepare for the blood loss that will occur during childbirth. Blood volume may eventually increase as much as 50% by the end of pregnancy. The number of red blood cells also increases. The speed of clotting increases to protect against excessive bleeding during delivery. By the end of pregnancy, the pregnant patient's heart rate increases up to 20% to accommodate the increase in blood volume. Cardiac output is significantly increased. In the third trimester, there is an increase of vomiting and potential aspiration following trauma because of the changes that occur in the gastrointestinal tract. Changes in the gastrointestinal mobility and the displacement of the stomach upward significantly increases the chance that pregnant trauma patient will vomit and aspirate if you are unable to clear her airway. Changes in the cardiovascular system and the increased demands of supporting the fetus significantly increase the workload of the heart. Remember, not all women are healthy when they begin pregnancy. Cardiac compromise is a life-threatening possibility. Weight gain during pregnancy is normal. The increase in body weight will eventually challenge the heart and impact the musculoskeletal system. Increased hormones affect the musculoskeletal system by making the joints looser or less stable. In the third trimester, changes in the body's center of gravity increase the risk of slips and falls. Complications of pregnancy. Most pregnant women are healthy, but some may be ill when they conceive or become ill during pregnancy. You may safely use oxygen to treat any heart or lung disease in a pregnant patient without harm to the fetus. Diabetes. Diabetes developed during pregnancy in many women who have not had diabetes previously. This condition, called gestational diabetes, resolves in most women after delivery. The treatment is the same for any other patient with diabetes. A pregnant woman may control her blood glucose level with diet and exercise or may take medications. In some cases, the woman will have to manage her condition with insulin injections. A pregnant woman experiencing hyperglycemia or hypoglycemia should be cared for in the same manner as any patient with diabetes. Hypertensive disorders. One complication that occasionally occurs, typically in patients who are pregnant for the first time, is preeclampsia, or pregnancy-induced hypertension. This condition can develop after the 20th week of gestation, characterized by the following symptoms: severe hypertension, severe or persistent headache, visual anomalies such as seeing spots, blurred vision or sensitivity to light, swelling in hands and feet, edema, and anxiety. A related condition is eclampsia, is characterized by seizures that can occur as a result of hypertension. To treat the patient having seizures caused by eclampsia, lay the patient on her left side, maintain her airway, administer supplemental oxygen if necessary. If vomiting occurs, suction the airway, provide rapid transport, and call for ALS intercept if available. Transporting the patient on her left side can also prevent supine hypotensive syndrome. This condition is caused by compression of the descending aorta and the inferior vena cava by pregnant uterus when the patient lies supine. Hypotension may result. Bleeding. Internal bleeding may be a sign of an ectopic pregnancy when an embryo develops outside the uterus, most often in the fallopian tube. Occurs about once in every 300 pregnancies. Leading cause of maternal death in the first trimester is internal hemorrhage into the abdomen following the rupture of an ectopic pregnancy. Consider the possibility of an ectopic pregnancy in a woman who has missed a menstrual cycle and complains of sudden, severe, unusually unilateral pain in the lower abdomen. Hemorrhage from the vagina that occurs before labor begins may be very serious. Call for ALS backup. In early pregnancy, it may be a sign of a spontaneous abortion or miscarriage. In the late signs of pregnancy, vaginal hemorrhage may indicate a serious condition involving the placenta. In abruptoplacenta, the placenta separates prematurely from the wall of the uterus, most commonly caused by hypertension or trauma. Patient often reports severe pain, but vaginal bleeding may not be heavy. In placenta previa, the placenta drops over and covers the cervix. Patient may experience heavy vaginal bleeding without significant pain. Decreasing the patient's anxiety during these situations can impact how she and the fetus may respond during an emergency. The figures on this slide show abruptoplacenta and placenta previa. Abortion. Passage of the fetus and the placenta before 20 weeks is called abortion. Abortions may be spontaneous miscarriage or induced. Deliberate abortions may be self-induced or planned and performed in a hospital or clinic. The most serious complications are bleeding and infection. Bleeding can result from portions of the fetus or placenta being left in the uterus, an incomplete abortion, or from injury to the wall of the uterus. Infection can result from such perforation and from the use of non-sterile instruments. If the woman is in shock, treat and transport her promptly to the hospital. Never try to pull tissue out of the vagina. Place a sterile pad on the vagina. Abuse. Pregnant women have an increased chance of being victims of domestic violence and abuse. Abuse during pregnancy increases the chance of spontaneous abortion, premature delivery, and low birth weight. The woman is at risk for bleeding, infection, and uterine rupture. Use a calm professional approach. Pay attention to the environment for any signs of abuse. Your attention to detail will be helpful in your documentation. Pregnant patients who are abused are often scared and may not be honest as to how their injuries may have occurred. Talk to the patient in a private area away from the potential abuser if possible. The best way for you to care for the fetus is to treat the pregnant woman. Substance abuse. Some pregnant women are addicted to alcohol or other drugs. The effects of addiction on the fetus include prematurity, low birth weight, severe respiratory distress, and death. Fetal alcohol syndrome describes the condition of infants born to women who have abused alcohol. If you are called to handle a delivery of an addicted woman, pay special attention to your own safety. Follow standard precautions. Wear eye protection, a face mask, and gloves at all times. Clues that you're dealing with an addicted patient may include the presence of drug paraphernalia, empty wine or liquor bottles, statements made by family or bystanders or by the patient herself. The newborn will probably need immediate resuscitation. Assist with the delivery and be prepared to support the newborn's respirations and administer oxygen during transport. Special considerations for trauma and pregnancy. With a trauma call involving a pregnant woman, you have two patients to consider, the woman and the unborn fetus. Trauma to pregnant women may have direct effect on the condition of the fetus. Pregnant women may be victims of many types of trauma, including assaults, motor vehicle crashes, shootings. Pregnant women also have an increased risk of falling compared with non-pregnant women. Hormonal changes loosen the joints in the musculoskeletal system. The increased weight of the uterus and displacement of the abdominal organs can affect a woman's balance. Pregnant women have an increased amount of overall total blood volume and approximately 20% increase in their heart rate by the third trimester. A pregnant trauma patient may experience a significant amount of blood loss before you detect signs of shock. The fetus also may be in trouble well before signs of shock are present. The body of a woman who has sustained serious trauma often reduces the blood supply to the fetus. Be alert to additional concerns and ready to assess and manage unique types of injuries when responding to a pregnant trauma patient. The uterus is especially vulnerable to penetrating trauma and blunt injuries. A trauma injury to a pregnant uterus can be life-threatening to the woman and fetus because the uterus has a rich blood supply. In most cases, the only chance to save the fetus is to adequately resuscitate the woman. When a pregnant woman is involved in a motor vehicle crash or a similarly violent mechanism of injury, severe hemorrhage may result from injuries to the pregnant uterus. Trauma is one of the leading causes of abruptoplacenta. You should suspect abruptoplacenta when the MOI is blunt trauma to the abdomen and the patient's signs and symptoms are suggestive of shock. Common signs include vaginal bleeding and severe abdominal pain. Quickly assess and transport the patient. Support the airway, administer high-flow oxygen, place sanitary pads on the vagina. Position the patient on her left side and call for ALS backup. Improper positioning of the seatbelt can result in the injury to the pregnant woman and the fetus if they are involved in a motor vehicle crash. Carefully assess a pregnant woman's abdomen and chest for seatbelt marks, bruising, and obvious trauma. If a pregnant trauma patient goes into cardiac arrest, your focus is the same as with other patients in cardiac arrest. Remember, the only chance you have to save the fetus is to do all you can to save the woman. Perform CPR and provide transport to the hospital according to local protocol. If the woman is in the last month or two of pregnancy, compressions may need to be applied a little higher on the sternum than usual. If possible, one provider should be assigned to manually displace the uterus towards the patient's left side to facilitate blood return to the right side of the heart. You should notify the receiving facility personnel as soon as possible that you are en route with a pregnant trauma patient in cardiac arrest. Assessment and management. Your focus is on the assessment and management of the woman. You should suspect shock based on the MOI. Be prepared for vomiting and anticipate the need to manage the airway to protect the patient from aspirating. Attempt to determine the gestational age to assist you when determining the size of the fetus and position of the uterus. Follow these guidelines when treating a pregnant trauma patient. Maintain an open airway. Be prepared for and anticipate vomiting. Keep your suction unit ready and available. Administer high-flow oxygen. Keep the oxygen saturation level high. Administer high-flow oxygen 100% by non-rebreather mask. Ensure adequate ventilations. Listen to breath sounds and confirm that bilateral breath sounds are present. If the patient's ventilations are inadequate, provide or assist ventilations with a bag valve mask and 100% oxygen. Assess circulation. Control external bleeding. Maintain a high index of suspicion for internal bleeding and shock based on the MOI. Keep the patient warm. Transport considerations. Transport the patient on her left side if the spinal injury is suspected. Tilt the backboard 30 degrees to the left. Transport the patient to the trauma center if one is available in your area. Cultural value considerations. Cultural sensitivity is important when you are assessing and treating a pregnant patient. Women of some cultures may have a value system that will affect the choice of how they care for themselves during pregnancy and how they have planned the childbirth process. Some cultures may not permit a male health care provider, especially in the pre-hospital setting, to assess or examine a female patient. You should respect these differences and honor the request from the patients. Your responsibility is to the patient and is limited to providing care and transport. A competent, rational adult has the right to refuse all and any part of your assessment or care. Teenage pregnancy. The United States has one of the highest teenage pregnancy rates among developed countries. It is likely that during your career you will respond to a pregnant teenager who may or may not be in labor. Pregnant teenagers may not know they are pregnant and may be in denial about it. As you begin to assess all female teenagers, remember that pregnancy is a possibility. Respect the teenager's privacy and need for independence. If possible, perform your assessment and obtain a history away from the teenager's parents. Become familiar with laws in your state so that you will know when pregnant teenagers can give and refuse consent for themselves. Patient assessment. Childbirth is seldom an unexpected event, but there are occasions when childbirth becomes an emergency. Dispatch protocols usually include the dispatcher asking simple questions to determine whether birth is imminent. Premature contractions may be caused by trauma or medical conditions. Scene size up. Take standard precautions. Gloves and eye and face protection are a minimum if delivery has already begun or is complete. If the call is going to result in a field delivery and time allows, a gown should also be used. Do not be lax in your safety observations and precautions. Remain calm and professional. Consider calling for additional or specialized resources. Mechanism of injury, nature of illness. You will encounter pregnant patients who are not in labor, so it is important to determine the MOI or NOI. Do not develop tunnel vision during the call. Falls and the necessity for spinal mobilization must be considered. Primary assessment. Form a general impression, whether the patient is in active labor or whether you have time to assess for imminent delivery and address other possible life threats. Perform a rapid examination of the patient. Take a moment to confirm whether the fetus will be delivered in the next few minutes or whether you have time to continue to evaluate the situation. When trauma or other medical problems are the presenting complaint, evaluate these first and then assess the impact of these problems on the fetus. Airway and breathing. During an uncomplicated birth, life-threatening conditions involving the woman's airway and breathing are not usually an issue. However, a motor vehicle crash, an assault, or any number of medical conditions may cause a life threat to exist and may result in a complicated delivery. Assess the airway and breathing to ensure they are adequate. If needed, provide airway management and high-flow oxygen. Circulation. External and internal bleeding are potential life threats to the patient and should be addressed early. Blood loss after delivery is expected, but significant bleeding is not. Quickly assess for any potential life-threatening bleeding and begin treatment immediately. Assess the skin for color, temperature, and moisture. Check pulses to determine if it is too fast or too slow. If there are signs of shock, control the bleeding, give oxygen, and keep the patient warm. Transport decision. If delivery is imminent, you must prepare to deliver at the scene. The ideal place to deliver is in the security of your ambulance or the privacy of the woman's home. The area should be warm and private with plenty of room to move around. If delivery is not imminent, prepare the patient for transport and perform the remainder of the assessment en route to the emergency department. Administer oxygen. Women in the second and third trimesters of pregnancy should be transported lying on the left side when possible. If spinal immobilization is indicated, secure the woman to a backboard and elevate the right side of the board with rolled towels or blankets. Provide rapid transport for pregnant patients who have significant bleeding and pain, are hypertensive, are having a seizure, or have altered mental status. History taking. You should obtain a thorough obstetric history including her expected due date, any complications that she is aware of, if she has been receiving prenatal care, a complete medical history. Obtain a sample history. Some pregnant women have history of medical problems for which they take prescription medications. Some women have no history of medical problems, require medications during pregnancy. Permanent history should include questions related specifically to prenatal care. Identify any complications the patient may have had during the pregnancy or potential complications during delivery. Determine the due date, fetal movement, frequency of contractions, and a history of previous pregnancies and deliveries and their complications. Determine whether there is a possibility of multiples or whether the woman has taken any drugs or medications. If her water is broken, ask whether the fluid was green. Green fluid is due to meconium, fetal stool. The presence of meconium can indicate newborn distress, and it is possible for the fetus to aspirate the meconium during delivery. Secondary assessment, physical examinations. Perform complete assessment of the major body systems as needed, with emphasis on the patient's chief complaint. Assess for fetal movement by asking the patient whether she can feel the baby moving. If the patient is in labor, the physical examination should be focused on contractions and possible delivery. If at any point you suspect the delivery is imminent, you should check for crowning. If you do not suspect an imminent delivery, the patient reports other problems unrelated to delivery, you should not visibly inspect the vaginal area. Vital signs should include pulse, respiration, skin color, temperature and condition, and blood pressure. Be especially alert for tachycardia and hypo or hypertension. If it is typical for a woman's blood pressure to drop slightly during the first 2 trimesters of pregnancy, but return to normal during the 3rd. Hypertension, even mild, may indicate more serious problems. Reassessment. Repeat the primary assessment with a focus on the patient's ABCs and vaginal bleeding, particularly after delivery. Obtain another set of vital signs and compare with those obtained earlier. Recheck interventions and treatments to see whether they are effective. Is vaginal bleeding showing with the uterine massage? In most cases, childbirth is a natural process that does not require your assistance. When childbirth is complicated by trauma or other conditions, however, any interventions you provide for the patient will benefit the fetus. Communication and documentation. If your assessment determines that delivery is imminent, notify staff at the receiving hospital. Provide an update on the status of the woman and the newborn after delivery. On rare occasions that delivery of the placenta has not occurred within 30 minutes or you determine that a complication is occurring that cannot be treated in the field, notify the hospital and provide rapid transport. For a pregnant patient with a complaint unrelated to childbirth, be sure to include the pregnancy status of the patient in your radio report. The hospital staff will want to know the number of weeks of gestation, her due date, any known complications of pregnancy, and if delivery occurred in the field, you will have 2 patient care reports to complete. Stages of labor. The 3 stages of labor are dilation of the cervix, delivery of the fetus, and delivery of the placenta. The first stage begins with the onset of contractions and ends when the cervix is fully dilated. The first stage is usually the longest lasting, an average of 16 hours for the first delivery. The onset of labor starts with the contractions of the uterus. Other signs of beginning labor are the bloody show and the rupture of the amniotic sac. The frequency and intensity of contractions in true labor increase with time. Uterine contractions become more regular and last about 30 to 60 seconds each. Labor is generally longer in a primigravida, a woman experiencing her first pregnancy, than in a multigravida, a woman who has experienced previous pregnancies. A woman may experience preterm or false labor or Braxton Hicks contractions. You should provide transport for the patient. If true labor is occurring, you may need to prepare for delivery. The table on this slide shows how to distinguish between true labor and false labor. Some women experience a premature rupture of membranes in which the amniotic sac ruptures too early and the fetus is not developed or ready to be born. The patient may or may not go into labor. You will need to provide supportive care and transport to the hospital. Towards the end of the 3rd trimester, the head of the fetus normally descends into the woman's pelvis as the fetus positions for delivery. This movement down into the pelvis and the sensation that may accompany the descent is called lightening. The second stage of labor begins when the fetus begins to encounter the birth canal and ends with the delivery of the newborn, spontaneous birth. During this stage, you will have to make a decision about helping the woman to deliver at the scene or providing transport to the hospital. Uterine contractions are usually closer together and last longer. Under no circumstances should you let the woman sit on the toilet. The peritoneum will begin to bulge significantly, and the top of the fetus's head should begin to appear in the vaginal opening. This is called crowning. The third stage of labor begins with the birth of the newborn and ends with the delivery of the placenta. During this stage, the placenta must completely separate from the uterine wall. This may take up to 30 minutes. Normal delivery management. Preparing for delivery. Consider delivery at the scene when delivery is imminent will occur within a few minutes. A natural disaster, inclement weather, or other environmental factors make it impossible to reach the hospital. To determine if delivery is imminent, ask the patient the following questions. How long have you been pregnant? When are you due? Is this your first pregnancy? Are you having contractions? How far apart are they, and how long did they last? Have you had any spotting or bleeding? Has your water broken? Do you feel as though you need to have a bowel movement? Do you feel the need to push? To help determine potential complications, ask these questions. Were any of your previous deliveries by cesarean section? Have you had problems in this or previous pregnancies? Do you use drugs, drink alcohol, or take any medications? Do you know if there is a chance you could have multiple deliveries? Does your physician expect any complications? If the patient says that she is about to deliver and says she has to move her bowels or feels the need to push, you should immediately prepare for delivery. Otherwise, does she have an extremely firm abdomen? Visually inspect the vagina to check for crowning. Do not touch the vaginal area until you have determined that delivery is imminent. Once labor has begun, it cannot be slowed or stopped. Never attempt to hold the patient's legs together. Do not let her go to the bathroom. Instead, reassure her that the sensation of needing to move her bowels is normal, and that means she's about to deliver. If your decision is to deliver at the scene, remember that you are only assisting the woman with delivery. Your part is to help guide and support the baby as it's born. You want to appear calm and reassuring while protecting the woman's modesty. Recognize when the situation is beyond your level of training. If there is any doubt, contact medical control for a decision to deliver on scene or to transport. Your emergency vehicle should always be equipped with a sterile emergency obstetric OB kit, including surgical scissors or scalpel, umbilical cord clamps, umbilical cord tape, a small rubber plunge syringe, towels, drapes, and sheets, 4x4 or 2x10 gauze sponges, sterile gloves, infant blanket, sanitary pads, an infant-sized BVM, goggles, and a plastic bag. Patient position. The patient's clothing should be removed or pushed up to her waist, and pants and undergarments should be removed. Remember to preserve the patient's privacy as much as possible. Place the patient on a firm surface that is padded with blankets, folded sheets, or towels. Elevate the hips about 2 to 4 inches with pillows or blankets. Support the head, neck, and upper back with pillows and blankets. Have her keep her legs and hips flexed, with her feet flat on the surface beneath her and her knees spread apart. Communicate with your crew and plan who will be responsible for caring for the mother and the newborn after delivery. If the emergency delivery is occurring at home, you should move the patient to a sturdy flat surface or the floor if she will allow it. Take the progression of delivery closely at all times. Preparing for delivery field. Put on a protective face shield and gown as time allows. Place towels or sheets on the floor around the delivery area to help soak up bodily fluids and to protect the woman and the newborn. Open the OB kit carefully so that its contents remain sterile. Put on the sterile gloves. After this, handle only sterile materials. Use the sterile sheets to drape and drapes from the OB kit to make a sterile delivery field. Place one drape under the patient's buttocks and unfold it towards her feet. Wrap another drape behind the patient's back and drape it over each thigh. Drape another sheet across her abdomen. The figures on this slide show how to prepare the delivery field. Delivery. Your partner should be at the patient's head to comfort, soothe, and reassure her during the delivery. If the patient will allow it, administer oxygen. It is common for patients to become nauseated during delivery, and some may vomit. If this occurs, have your partner assist her and clear out her airway. Continually check the patient for crowning. Some patients may experience precocious labor and birth. Position yourself so that you can see the perineal area at all times. Time the patient's contractions. Remind the patient to take quick, short breaths during each contraction, but not to strain. Between contractions, encourage the patient to rest and breathe deeply through her mouth. Follow the steps in skill drill 33-1 to deliver the newborn. Delivering the head. Observe the head as it begins to exit the vagina so you can provide support as it emerges. Place your sterile gloved hand on the emerging bony parts of the head to control the delivery of the head. Continue to support the head as it rotates. Apply gentle pressure across the perineum with a sterile gauze pad to reduce the risk of perineal tearing. Be prepared for the possibility of the patient having a bowel movement because of the increased pressure on the rectum. Be careful you do not poke your fingers in the newborn's eyes or into the fontanelles. Unruptured amniotic sac. Usually the amniotic sac will rupture at the beginning of labor or during contractions. If it has not ruptured by the time the fetal head is crowning, it will appear as a fluid-filled sac emerging from the vagina. The sac will suffocate the fetus if it is not removed. You may puncture the sac with a clamp or tear it by twisting it between your fingers. Make sure that the puncture site is away from the fetus's face and only perform this procedure as the head is crowning. Clear the newborn's mouth and nose using the bulb syringe if required by your protocols and wipe the mouth and nose with gauze. If amniotic fluid is greenish, notify the receiving hospital. Umbilical cord around the neck. As soon as the head is delivered, use one finger to feel whether the umbilical cord is wrapped around the neck. This is commonly called a nuchal cord. The nuchal cord that is wound tightly around the neck could strangle the fetus. Usually you can slip the cord gently over the delivered head. If not, you must cut it. Once the cord is cut, you must attempt to speed the delivery by encouraging the woman to push harder, and possibly more often because the fetus will now have no oxygen supply until it is delivered and breathing spontaneously. Delivering the baby. Once the head has been delivered, it usually rotates to one side or the other. This rotation places the body in a better position for delivery. The head is the largest part of the fetus. Once it is born, the body usually delivers easily. Support the head and upper body as the shoulders deliver. Do not pull the fetus from the birth canal. The newborn will be slippery and covered with a white, cheesy substance called vernix carcosa. Post-delivery care. If the mother is able and willing, hand the newborn to her and place the newborn on her abdomen so skin-to-skin contact can begin immediately. Dry off the newborn and wrap him or her in a blanket or towel. Wrap the newborn so that only the face is exposed, making sure the top of the head is covered. Place the newborn on one side with the head slightly lower than the rest of the body. You can pick up and cradle the newborn. If local protocols specify, keep the newborn at the level of the woman's vagina until the umbilical cord is cut. Always keep the head slightly downward to help prevent aspiration. Wipe the newborn's mouth with a sterile gauze pad as needed. Post-delivery care of the umbilical cord is important because infection is easily transmitted through the cord to the newborn. Once the cord has stopped pulsing, clamp and cut the cord. Elevate the newborn for term gestation, good muscle tone, breathing, cry, and obtain a 1-minute APGAR score. Give the wrapped newborn to your partner to complete the initial care. You can give the newborn to the mother if she is alert and in stable condition. Delivery of the placenta. The placenta is attached to the end of the umbilical cord that is coming out of the woman's vagina. Again, your job is only to assist. The placenta delivers itself, usually within a few minutes of birth, although it may take up as long as 30 minutes. Do not delay transport waiting for the placenta to deliver. Never pull on the end of the umbilical cord. Some bleeding, usually less than 500 milliliters, occurs before the placenta delivers and is normal and expected. Wrap the entire placenta and cord in a towel, place them in a plastic bag, and take them to the hospital. After delivery of the placenta and before transport, place a sterile pad or sanitary napkin over the vagina and straighten the woman's legs. You can help to slow the bleeding by gently massaging the woman's abdomen with a firm circular kneading motion. You should be able to feel a firm grape-sized mass in the lower abdomen called the fundus. Record the time of birth in your patient care report. The following emergency situations: more than 30 minutes elapsed and the placenta has not been delivered. There is more than 500 milliliters of bleeding before delivery of the placenta. There is significant bleeding after delivery of the placenta. If one or more of these events occur, transport the woman and the newborn to the hospital promptly. Neonatal assessment and resuscitation. Follow standard precautions. Always put on gloves before handling a newborn. A newborn will usually begin breathing spontaneously within 15 to 30 seconds after birth. The heart rate will be 120 beats per minute or higher. If you do not observe these responses, gently tap or flick the soles of the feet and rub the back. Many newborns require some form of stimulation that will encourage them to breathe air and begin circulating blood through their lungs, including positioning of the airway, drying, warming, suctioning, and tactile stimulation. The table on this slide shows how to perform resuscitation of a newborn who is not breathing. To maximize the efforts of these measures, follow these tips. Position the newborn on his or her back with the head down and neck slightly extended. Place a towel or blanket under the shoulders to help maintain this position. If necessary, suction the mouth, then the nose with the bulb syringe or suction device with a 8 or 10 French catheter. Suction both sides of the back of the mouth, but avoid deep suctioning of the mouth and throat. Aim blow-by oxygen by the newborn's mouth and nose during resuscitation. In addition to drying the newborn's head, back, and body vigorously with dry towels, you may rub the newborn's back and flick or slap the soles of his or her feet. Additional resuscitation efforts. Observe the newborn for spontaneous respiration, skin color, and movement of extremities. Evaluate the heart rate by palpating the pulse at the base of the umbilical cord or the brachial artery, or listening to the newborn's chest with a stethoscope. The heart rate is the most important measure in determining the need for further resuscitation. The table on this slide shows additional neonatal resuscitation efforts. If chest compressions are required, use the hand encircling technique for two-person resuscitation. Perform BVM ventilations during a pause after every third compression, using compression to ventilation ratio of 3:1. This will yield a total of 120 actions per minute, 90 compressions and 30 ventilations. The figures on this slide show how to give chest compressions to a newborn using the hand encircling technique. Any newborn who requires more than routine resuscitation requires transport to the hospital with Level 3 neonatal intensive care unit. About 12% to 16% of deliveries are complicated by the presence of myocotum. If you see myocotum in the amniotic fluid or myocotum staining on the newborn is not breathing adequately, consider quickly suctioning the newborn's mouth, then nose after delivery before providing rescue ventilations. The APGAR score. The APGAR score is a standard scoring system used to assess the status of a newborn. It assigns a number value, 0, 1, or 2, to 5 areas of activity. Appearance: the skin of a light-skinned newborn and the mucosal membranes of a dark-skinned newborn should turn pink. Blue skin all over or blue mucosal membranes signal a central cyanosis. Pulse: if the stethoscope is unavailable, you can measure pulsations with your fingers in the umbilical cord, or brachial pulse. A newborn with no pulse requires immediate CPR. Grimace or irritability. Grimacing, crying, or withdrawing in response to stimuli is normal in a newborn and indicates that the newborn is doing well. The way to test this is to snap your fingers against the sole of the newborn's foot. Activity or muscle tone. The degree of muscle tone indicates the oxygenation of tissues. Normally, the hips and knees are flexed at birth, and to some degree, the newborn will resist straightening them out. A newborn should not be floppy or limp. Respirations. Normally, a newborn's respirations are regular and rapid with a good strong cry. If the respirations are slow, shallow, or labile, or if the cry is weak, the newborn may have respiration insufficiency and need assistance with ventilations. Complete absence of respirations or crying is a very serious sign. The total of 5 numbers in the APGAR score. A perfect score is 10. Calculate the APGAR score at 1 minute and 5 minutes after birth. The table on this slide shows how to calculate the APGAR score for a newborn. Follow these steps in assessing a newborn. Quickly calculate the APGAR score to establish a baseline of the newborn's status. Stimulation should result in an immediate increase in respiration rate. If not, you should begin ventilations with a BVM. If the newborn is breathing well, you should next check the pulse rate by feeling the brachial pulse or pulsations at the base of the umbilical cord, or auscultating the chest with a stethoscope. The pulse rate should be at least 100 beats per minute. If it is not, begin ventilations with a BVM. Reassess respirations and heart rate at least every 30 seconds. Address the newborn's oxygenation via pulse oximetry and observe for central cyanosis. If present, administer blow-by oxygen by holding the oxygen tubing at high flow close to the newborn's face. Set oxygen flow rate to 5 liters a minute. You should request a second unit as soon as possible if you determine that the newborn is in any distress and will require resuscitation. In situations where assisted ventilation is required, you should use a newborn BVM. Make sure you have a good mask-to-face seal. Using gentle pressure, make the chest rise with each ventilation. If the newborn does not begin breathing on his or her own or does not have an adequate heart rate, continue CPR and rapidly transport. Once CPR has started, do not stop until the newborn responds or is pronounced dead by a physician. Complicated delivery emergencies. Breech delivery. The presentation is the position in which the infant is born or the body part that is delivered first. Most infants are born head first, called Vatex presentation. Occasionally, the buttocks is delivered first, called breech presentation. If the fetus is at great risk for trauma from this delivery. Prolapse cords are the most common in breech delivery. Breech deliveries usually take longer, so you will often have time to transport the pregnant woman to the hospital. However, if the buttocks have already passed through the vagina, the delivery has begun. Provide emergency care and call for ALS backup. If the woman does not deliver within 10 minutes of the buttocks presentation, provide prompt transport. Contact medical control to guide you. Preparing for breech delivery is the same as for normal childbirth. Position the pregnant woman, prepare the OB kit, place yourself and your partner as you would for a normal delivery. Allow the buttocks and legs to deliver spontaneously, supporting them with your hand to prevent rapid expulsion. Let the legs dangle on either side of your arm while you support the trunk and chest as they are delivered. The head is almost always face down and should be allowed to deliver spontaneously. Make a V with your gloved hand and position them in the vagina to keep the walls of the vagina from compressing the fetus's airway. Presentation complications. On rare occasions, the presenting part of the fetus is neither the head nor the buttocks, but a single arm, leg, or foot. This is called limb presentation. An infant with limb presentation cannot be successfully delivered in the field. Usually surgery is needed. You must transport the patient to the hospital immediately. If the limb is protruding, cover it with a sterile towel. Never try to push it back in, never pull on it. Place the patient on her back with her head down and pelvis elevated. Remember to give the woman high-flow oxygen. Prolapse of the umbilical cord, where the umbilical cord comes out of the vagina before the fetus, must be treated in the hospital. The fetus's head will compress the cord during childbirth and cut off circulation to the fetus, depriving it of oxygenated blood. Do not attempt to push the cord back into the vagina. There is usually time to get the patient to the hospital. Your job is to try to keep the fetus's head from compressing the cord. Place the pregnant woman supine with the foot of the cot raised 6 to 12 inches higher than the head, with her hips elevated on a pillow or folded sheet. Alternately, the woman may be placed in the knee-chest position, kneeling and bent forward face down. Either of these positions will help keep the weight of the fetus off the prolapse cord. Carefully insert your sterile gloved hand into the vagina and gently push the fetus's head away from the umbilical cord. Wrap a sterile towel moistened with saline around the exposed cord. Give the patient high-flow oxygen and transport rapidly. Spinal bifida. Spinal bifida is a developmental defect in which a portion of the spinal cord or manganese may protrude outside of the vertebrae and possibly outside of the body. When it protrudes outside of the body, it is seen on the newborn's back and usually occurs in the lower third of the back in the lumbar area. Cover the area of the spinal cord with a sterile moist dressing immediately after birth to help prevent a potentially fatal infection. Maintenance of the newborn's body temperature is important when applying moist dressings because the moisture can lower the newborn's body temperature. Have someone hold the newborn against his or her body. Multiple gestation. Twins occur about once in every 30 births. Usually multiple fetuses are diagnosed early in pregnancy with modern ultrasound techniques. When multiple fetuses, also be prepared for more than one resuscitation and call for assistance. Twins are usually smaller than single fetuses and delivery is typically not difficult. Consider the possibility of the twins any time the first newborn is small or the woman's abdomen remains fairly large and firm after birth. If twins are present, the second one is usually born within 45 minutes of the first. About 10 minutes after the first birth, contractions will begin again. The birth process will repeat itself. The procedure of delivering twins is the same as that for a single fetus. However, you will need some supplies from an additional OB kit. Clamp and cut the cord of the first newborn as soon as it's been born and before the second newborn is delivered. There may only be one placenta, or there may be two. Record the time of the birth of each twin separately. Twins may be so small that they look premature. Handle them carefully and keep them warm. Premature birth. A normal full-term single newborn will weigh approximately 7 pounds at birth. Any newborn who delivers before 8 months, or 36 weeks, or weighs less than 5 pounds at birth is considered premature. A premature newborn is smaller and thinner than a full-term newborn, and the head is proportionally larger in comparison with the rest of the body. The varix cansosa will be absent or minimal on premature newborn. There will also be less body hair. Premature newborns require special care to survive. They often require resuscitation efforts which should be performed unless it is physically impossible. With such care, premature newborns are small as 1 pound have survived and developed normally. Post-term pregnancy. Post-term pregnancy refers to pregnancies lasting longer than 42 weeks. Post-term fetuses can be larger than a typical 40-week fetus, sometimes weighing 10 pounds or more. This condition can lead to problems with the woman and fetus, a more difficult labor and delivery. Increased chance of injury to the fetus, increased likelihood of a cesarean section being required. Women is at risk for perineal tearings and infection. Post-term newborns have increased risk of myocardium aspiration infection and being stillborn. Newborns may not have been able to develop normally because of restricted size of the uterus. You should be prepared to resuscitate the newborn, and as respiratory and neurologic functions may have been affected. You may find yourself delivering a fetus who died in the woman's uterus before labor. The onset of labor may be premature, but the labor will otherwise progress normally in most cases. If a uterine infection has caused the demise, you may note an extremely foul odor. The delivered fetus may have skin blisters, skin sloughing, or dark discoloration. The head will be soft and possibly grossly deformed. Do not attempt to resuscitate an obviously dead neonate. Delivery with sterile supplies. On rare occasions, you may have to deliver a newborn without a sterile OB kit. Even without the OB kit, you should always have eye protection gloves and a protective mask with you. Carry out the delivery as if sterile supplies were available. If possible, use freshly laundered sheets and towels. As soon as the newborn is delivered, wipe the inside of the mouth with your finger to clear away blood and mucus. You should not cut or clamp the umbilical cord. Instead, as soon as the placenta delivers, wrap it in a clean towel or put it in a plastic bag and transport it to the hospital. Always keep the placenta and the newborn at the same level, or elevate the placenta slightly if possible. Keep the newborn warm. Postpartum complications. Bleeding that exceeds 500 milliliters is considered excessive. If bleeding continues after delivery of the placenta, you should continue to massage the uterus. Check your techniques and hand placement if bleeding continues. Treat the woman if she appears to be in shock. Excessive bleeding after birth is usually caused by the muscles of the uterus not fully contracting due to delivery of more than one infant, a long labor process that causes the uterus to be too tired to contract, parts of the placenta still being inside the uterus. Cover the vagina with a sterile pad, changing the pad as often as possible. Do not discard any blood-soaked pads. The hospital personnel will use them to estimate the amount of blood loss, save any tissue that may be passed from the vagina, administer oxygen if necessary, monitor vital signs frequently, and transport the patient immediately to the hospital. Never hold the woman's leg together or pack the vagina with gauze pads in an attempt to control bleeding. Postpartum patients are also at an increased risk of an embolism, most commonly a pulmonary embolism. A pulmonary embolism results from a clot that travels through the bloodstream and becomes lodged in the pulmonary circulation, blocking blood flow to the lungs and potentially life-threatening. If you deliver a newborn in the field and the woman begins to report sudden difficulty breathing or shortness of breath, consider pulmonary embolism as a possibility. Also suspect a pulmonary embolism if the patient of childbearing age with respiratory complaints who have recently delivered, especially with the sudden onset of difficulty breathing or altered mental status. Provide supportive care of the ABCs with high-flow oxygen and rapid transport to the hospital. Okay, class, let's go over some review questions. Review question 1. The first stage of labor ends when A. The presenting part of the baby is visible. B. Contractions are less than 10 minutes apart. C. The mother experiences her first contraction. D. The amniotic sac ruptures and labor pains begin. The correct answer is A. The first stage of labor begins with the onset of contractions and ends when the cervix is fully dilated. However, since the cervical dilation cannot be assessed in the field, the first stage of labor is considered over when the presenting part of the baby is visible at the vaginal opening, crowning. A is the correct answer. B, true labor is when the frequency and intensity of contractions increase and is part of the first stage of labor. C, this is the beginning of the first stage of labor. D, this is considered to be part of the first stage of labor. Review question 2. A 23-year-old woman who is 24 weeks pregnant with her first baby complains of edema of her hands, a headache, and visual disturbances. When you assess her vital signs, you note her blood pressure is 160/94. She is most likely experiencing A. Eclampsia, B. Preeclampsia, C. A hypertensive crisis, D. Chronic water retention. The correct answer is B. Preeclampsia, also called pregnancy-induced hypertension, usually develops about the 20th week of gestation and most commonly affects prima gravida, first pregnancy patients. It is characterized by a headache, visual disturbances, edema of the hands and feet, anxiety, and high blood pressure. Preeclampsia can lead to eclampsia, a life-threatening condition that is characterized by seizures. Answer A. Eclampsia is the seizure that results from severe hypertension. The correct answer is B. C. This is a severe sudden increase in blood pressure, typically greater than 110 diastolic, that can lead to a stroke. Answer D. This is a fluid imbalance usually caused by too much sodium in the body. Review question 3. You are transporting a woman who is 8 months pregnant. To prevent supine hypotensive syndrome, you should have positioned this patient A. on her right side, B. supine, C. semi-Fowlers, or D. on her left side. The correct answer is D. To prevent supine hypertensive syndrome, the patient must be positioned on her left side. This stops the weight of the fetus from compressing the inferior vena cava, which can cause low blood pressure. A. The patient should be transported on her left side. B. Lying the patient supine will cause hypotension. C. The patient should be transported on her left side, and D is the correct answer. Review question 4. Immediately after you deliver the infant's head, you should A. Suction the baby's mouth and then nose. B. Suction the baby's nose and then mouth. C. Assess the baby's breathing, effort, and skin color. D. Check the position of the umbilical cord. The correct answer is D. Immediately following delivery of the infant's head, you should check the position of the umbilical cord to make sure it is not wrapped around the baby's neck. If nuchal cord is not present, suction the infant's mouth and nose. A. After EMS has confirmed that the cord is not around the infant's head, this should be performed. The same for B. C. This cannot be performed until the entire infant has been delivered completely. D is the correct answer. Review question 5. Upon delivery of the baby's head, you note the umbilical cord is wrapped around the neck. You should A. Immediately clamp and cut the cord. B. Make one attempt to slide the cord over the head. C. Keep the cord moist and transport as soon as possible. D. Give the mother high flow oxygen and transport rapidly. The correct answer is B. If the umbilical cord is wrapped around the baby's neck, you should make one attempt to gently remove the cord from around the baby's neck. If this is not possible, the cord should be clamped and cut. Keep the cord moist, administer high flow oxygen to the mother, and transport at once. A. Do this only after an attempt is made to slide the cord over the infant's head. B is the correct answer. C. This is the treatment for deliveries where the cord presents and not the infant's head. D. Do this only after an attempt to slide the cord over the infant's head. Review question 6. The need for and extent of newborn resuscitation is based on A. The 1-minute APGAR score. B. The gestational age of the newborn. C. The newborn's response to oxygen. D. Respiratory rate, heart rate, and color. The correct answer is D. The need for and the extent of newborn resuscitation is based on respiratory effort, heart rate, and skin color. The APGAR score is not used to determine if resuscitation is needed. The first score is not assigned until the newborn is 1 minute of age. Resuscitation, if needed, should commence immediately. A. The APGAR score is not used to determine if resuscitation is needed. B. The premature gestational age may indicate a higher risk for the infant, but does not indicate if resuscitation is required. C. Oxygen response is elevated by respiratory rate, heart rate, and color. D is the correct answer. Review question 7. The 1-minute APGAR score of a newborn reveals that the baby has a heart rate of 90 beats per minute, a pink body but blue hands and feet, and rapid respirations. The baby cries when the soles of its feet are flicked and resists attempts to straighten its legs. You should assign the APGAR score of A. 4, B. 6, C. 8, or D. 9. The correct answer is C. The APGAR score, which is obtained at 1 minute and 5 minutes after birth, assigns a numeric variable of the following 5 areas: appearance, pulse, grimace, activity, and respirations. A heart rate of 100 beats per minute is assigned a 1. A pink body with blue hands and feet is assigned a 1. Rapid respirations is a 2. A strong cry in reaction to painful stimuli is a 2. And resistance against an attempt to straighten the hips and knees is a 2. Added together, the APGAR score for this infant is an 8. The correct answer is 8. C is the correct answer. Review question 8. The most effective way to prevent cardiopulmonary arrest in a newborn is to A. Rapidly increase its body temperature. B. Allow it to remain slightly hypothermic. C. Ensure adequate oxygenation and ventilation. D. Start CPR if the heart rate is less than 100 beats per minute. The correct answer is C. Cardiopulmonary arrest in infants and children, including newborns, is most often a result of respiratory arrest. Therefore, ensuring adequate oxygenation and ventilation at all times is critical. It is also important to maintain the infant's body temperature and prevent hypothermia. A. It is important to maintain the infant's body temperature and prevent hypothermia. B. Hypothermia and shivering will deplete the infant's glucose and cause hypoglycemia. Correct answer is C. D. Start CPR when the heart rate is less than 60 beats per minute and not increasing with adequate ventilations. Review question 9. While assisting a woman in labor, you visualize her vagina area, see an arm protruding from her vagina. She tells you that she feels the urge to push. You should A. Cover the arm with a sterile towel and transport immediately. B. Encourage her to keep pushing as you prepare for rapid transport. C. Insert your gloved fingers into the vagina and try to turn the baby. D. Instruct the mother to keep pushing and give her high flow oxygen. The correct answer is A. Limb presentations do not deliver in the field, period. If the mother feels the urge to push, instruct her to stop. She should pant instead. Cover the protruding limb with a sterile towel. Administer high flow oxygen to the mother and transport immediately. Delivery must take place in the hospital. A is the correct answer. B. EMS cannot successfully deliver such a presentation in the field. C. You should only do this to create an airway for the infant in a breech position. D. EMS cannot successfully deliver such a presentation in the field. Review question 10. A newborn is considered to be term if it is born after blank weeks and before blank weeks. A. 34 and 37. B. 37 and 42. C. 38 and 44. D. 39 and 43. The correct answer is B. A term gestational range between 37 to 42 weeks. An infant who is born before 37 weeks gestation or weighs less than 5 pounds, regardless of gestational age, is considered premature. An infant born after 42 weeks is considered past due. Answer A. A newborn is considered premature if he or she is born before 37 weeks. Answer B is the correct answer. Answer C. A newborn is considered past due if he or she is born after 42 weeks. Answer D. A newborn is considered due if he or she is born after 42 weeks. Okay, class, this concludes the lecture on Chapter 33, Obstetrics and Neonatal Care. If you have any questions or concerns, please contact your instructor, and I will see you in the next chapter.